Hello, this is Dr. Ed Kim, and this is the first podcast on our module on cancer, and we'll be talking about staging. After this podcast, you should have a better understanding of the concept of staging. You should know that it is a stepwise progression or a process that includes clinical staging, surgical, pathologic staging, and true stage. Colorectal cancer will be used as an example to illustrate this. So what does it mean to stage a cancer? Most of us recognize that it's basically trying to figure out how far the cancer is spread. It's important for prognosis, it helps guide treatment, and the most common system that you're aware of is the T&M classification, where T stands for tumor, N stands for node, and M stands for distant metastases. So if we take a step back, I want to emphasize that staging is an estimate or a best guess of how far the cancer has spread. This imprecision in how we stage cancer has really significant implications for patient care. And this is also the source of the anxiety that people have with regard to having a cancer in terms of the fear of it coming back. So the easiest type or easiest case that are for staging are the ones that have already spread. So the person on the left unfortunately has liver full of lesions indicating distant metastases from a primary cancer. In this case, you already know that the cancer is spread. There's no mystery with regard to its extent. And the patient on the right, the CT scan does not show any lesions in the liver, but he or she may have micrometastatic disease that you just can't detect. So these are the patients or people that initially come in who are thought to have potentially curable cancer, but we don't know for sure. As I said, microscopic spread is often beyond our ability to detect accurately. You may think that with all the high-tech imaging studies such as the PET-CT, MRIs, and mutation analysis, and other modalities that we may be very good at being able to assess with high degree of accuracy how far the cancer has spread. But the actual picture is really not the case. We rely on a lot of indirect and imprecise information to estimate the true extent of disease and guide treatment. You might be surprised at the end of the module itself how many patients actually get overtreated or undertreated, or more often overtreated actually, because of this uncertainty and because of the significant consequence of undertreatment. So as I said, staging is a stepwise process that starts with clinical staging, which is essentially gathering all the information from non-invasive studies, labs, physical exam history. And then in some cases you gather more information with a resection of the tumor with the surgical pathologic stage. And then underlying all of this is the true stage of the cancer, which may not really be known until many years out. So let's go with an example. Mr. A is a 65-year-old man who unfortunately didn't have his screening colonoscopy and was found to have rectal bleeding and eventually had a colonoscopy that showed a colon cancer on exam and biopsy. And the right lower picture shows a biopsy of abnormal colon cells invading in the submucosa. He has a normal exam, CEA is normal. CT shows some thickening of the cecum, but it doesn't show any lesions in the liver or any lymphadenopathy. But I have to warn you that CT is not very good for lymphadenopathy, but it is reasonably reliable for liver metastases. Chest X-ray is also normal, and then in summarizing the case, you have to ask yourself what the stage of this cancer's patient is. So I'm going to provide you with some background information on colon cancer staging. Like most cancers, it has 4 stages. And the T staging has to do with the depth of invasion. So T1, 2, 3, 4. 1 is the most superficial tumor that goes into the submucosa. T goes into the muscularis propria. 3 goes into the serosa, and 4 into surrounding structures. So that's T1, 2, 3, 4. And for stage 1 and stage 2 cancers, those are the tumors that have just the primary tumors detected. Once they're spread into the lymph node, the N stage, then it becomes a stage 3 cancer. And stage 4, obviously, are the ones that have spread into distant sites, most commonly the liver, since it is the drainage basin from a hematologic standpoint. Okay. So for going back to Mr. A, what is the stage of his cancer? Well, at this point, we really actually don't know that much information. We know that he has at least a T1 because it's a cancer, but we don't know if it's a T2 or 3. It might probably not T4, at least on the CT scan. We probably would see some abnormalities in the surrounding structures. N, as I said, is pretty unreliable, and M is fairly reliable, but obviously has limits as well. So in reality, he's a T1 through 4 NX MX. So he could either be stage 1, 2, 3, probably not 4, but within reason, it's probably 1, 2, or 3. So what good is this information when there's so little of it, right? I think the best we can say is that the tumor seems confined to the colon, but we don't know for sure. What do we do now? And this is where you have to understand clinical staging, in essence, is a type of working diagnosis. You don't necessarily know the true diagnosis, but you know enough to be able to take some action. And taking some action means analogous to how I do, empiric treatment. Maybe not quite a great analogy, but so for stage 1, a clinical stage 1, the patient goes to the operating room for a colectomy. Stage 2, also the patient goes to the operating room for a colectomy. In stage 3, the patient goes to the operating room for a colectomy and then undergoes chemotherapy afterwards. And stage 4, the patient has chemotherapy and may have an operation if they have a complication related to the tumor. So if we go back to Mr. A's clinical diagnosis or his working diagnosis, the working diagnosis is that he probably has stage 1, 2, or 3. So in that case, looking at this list, we are able to take action with this patient and have him go to the operating room for a colectomy for an attempt at removing the tumor and a chance for cure. So before the operation, so after the operation, right, the patient, he ended up having a right hemicolectomy, and the specimen that was studied by the pathologist showed that he had a T3 lesion with multiple lymph nodes that were positive. And because of this additional information, we now have a more accurate sense of how far the cancer is spread. The surgery itself has provided us information regarding his lymph node status, which is in this case unfortunately positive. So he's stage 3. So we went from stage 1 to probably stage 1, 2, 3 to stage 3 now. So are we getting closer to truth? Yes, I think we can say that we are getting closer to the truth. So from Mr. A's standpoint, he is hoping that his cancer has been removed and he has an excellent chance for cure, but we don't know, and that's what the psychological burden of patients with cancer have. Is this the true stage of his cancer? Well, unfortunately, 1 year surveillance came around. He had a colonoscopy and had a PET CT performed. Colonoscopy showed that there were no intraluminal abnormalities, no recurrence at the anastomosis. But on the PET CT, he had, as you can see, lesions in his liver. So what is his stage now? So unfortunately, T3N2M1. So he is stage 4. So what you have to realize is that what was his true stage from the start? And I think you can say in this case that most likely his true stage was already a stage 4. He already had micrometastatic disease. We just weren't able to recognize it. And I know you guys should have seen some survival curves with a cancer. And this one's a little bit odd in that it goes all the way to 13 years, but mostly follow-up, we usually say about 5 years. So I would draw the line around 5 years. But if you look at the survival curves for cancer, you'll see that even early stage, and if you look at the ones with recurrence-free survival or cancer-related survival, you will see that even patients who are deemed to be stage 1 or stage 2 will have mortality or will die from their cancer after 4 or 5 years, that they will have metastatic recurrences. So, and recurrences in this case is a bad word. It's more like persistence of the disease. It means that the true stage really wasn't recognized, or we were not able to, and it's not because we were making a mistake. It was just a limitation of our current medical technology. So if you look at Mr. A's case, he was stage 3. And if you follow the line over, patients with stage 3, and again, this is overall survival, so people could be dying from cardiovascular or other diseases. So in this graph, it says they have about 60% survival. I would say classically, we say stage 3 patients have about 30% chance of recurrence, or 30% or 70% survival without, without or cancer-related survival. So for stage 3 patients, once you recognize that, then you need to recognize that 30% of those are actually stage 4 cancer patients, some of which you can turn into stage 3 with chemotherapy, but a majority of them are going to recur if they are true stage 4 cancer patients that we weren't able to identify from the start. So in summary, I want you to recognize that staging cancer can be a multi-step process. We start with the clinical. It is a working diagnosis. It's not perfect. It's the least accurate, but it often provides us enough information to take steps with regard to treatment. Then, if surgery is necessary for a lot of solid organ tumors, surgery can provide additional information to provide us better idea of where this cancer is going and how far it's spread. And then you have the true stage, which, like I said, if it's spread from the very start and you can see it and it's obvious, that's the easiest. But the challenging ones and the ones that we deal with more are the ones that may be micrometastatic that we just can't identify. And you will see that we use indirect information such as their known pathologic stage to get an estimate of what the likelihood of them being stage 4. So I want you to understand that it is a best guess, an estimate, an extent of disease. Although it may seem like with all the technology that we should have this down to a more precise science, it isn't, unfortunately, for many cancers. And that from a patient standpoint, this is where the idea of cancer coming back comes from. But you need to understand it's more accurate to think of it as the cancer still being there. Well, thank you for listening, and hope to see you guys for the classroom session.